Hello, I'm Shaneese. I'm a second-year resident at Magnolia Regional Healthcare Center in Corinth, Mississippi. That's in a rural area in Mississippi. We have a large catchment area. We're about an hour and a half away from Memphis, 2.5 hours away from Vanderbilt, and about 3.5 hours away from UAB. So we have a very unique patient population, and we see a lot of diverse patients and a lot of pathology. I'll be presenting a case report on Leriche syndrome and unusual left lower extremity pain. So Leriche syndrome is a occlusion of the distal abdominal aorta, and also occlusion of the with occlusion of the iliac arteries as well. There's well-documented cases in men. There's very limited research and literature about the case in women. Common factors that lead to the diagnosis is a history of hypertension, smoking, hyperlipidemia, and diabetes. So a 79-year-old Caucasian female presented to RED with left lower extremity pain that awoke her from her sleep. She said the pain was excruciating and she had never felt anything like that before. The day before, she had a urologic procedure performed, and the nurse noted her left lower extremity to be cool, and she was had diminished pulses, and the nurse recommended her to go to the ER, but the patient was adamant she didn't want to go to the ER, and they called her cardiologist, and the cardiologist said that he would see her in clinic within the next couple of days. She went home, went to sleep, woke up in severe excruciating pain, then presented to RED. Upon her presentation, she had a right BK, and she also had a history of COPD. She had a history of AFib. She had a history of hypertension, history of hyperlipidemia, also had a previous aortoiliac bypass graft performed 30 years ago in Memphis. Didn't follow up with that surgeon, so didn't know much about what was going on, was a poor historian for what was going on in that part. On my physical exam, the left lower extremity was significantly cooler than the right lower extremity. It was cyanotic. I was not able to palpate a pulse, so I went and got the Doppler, and I was not able to auscultate a pulse either. I had this case in the first 6 months of my intern year, so I went and talked to my attending, and he's like, "You can't feel it and you can't hear it," and I was like, "No." So then he presented to the room, and he was not able to palpate a pulse and use the Doppler as well, and was not able to auscultate anything either. On arrival to the ED, she was slightly hypertensive, but all her other vital signs were within normal limits. After these findings, we decided to proceed with a CTA of the bilateral lower extremities, and that CTA of the bilateral lower extremities revealed a severe occlusion of her distal abdominal aorta with 90% occlusion. Also, there was occlusion of her previous graft, and there was occlusion of her common iliacs, occlusion of her internal iliacs, and an occlusion of her external iliacs as well. After that, we consulted cardiology. Cardiology recommended that we start a heparin drip on her. Since we're in this rural area, we do have a limited amount of services, but we do have cardiovascular surgery. Cardiovascular surgery was not on call, but they did accept our call, and they recommended that we send her to a level 1 center, talk to the patient about it, but she was adamant that she didn't want to travel far and she wanted to stay at the hospital. So we honored her wishes, and then cardiovascular surgery went and evaluated her the next day, and they deemed that that left lower extremity was unreconstructable, secondary to severe peripheral artery disease, and they recommended an amputation. She did not want the amputation, so general surgery came and saw her. General surgery also recommended an amputation as well. She said no. Next day, the family came, talked to her, and she did proceed with that left lower extremity amputation as well. Given that she already had the previous right below the knee amputation and this new left below the knee amputation, she did go to a skilled nursing facility, was there a couple of months, then presented back to our ICU and did succumb to her injuries. I chose this case because there is literature about Leriche syndrome, but a majority of the literature is about males, and males will present with the triad of symptoms: claudication of the buttocks and thighs, erectile dysfunction, and they also will present with decreased sensation, and their presentation is more gradual in onset. over like the 3rd to 6th decades of life. With women, there are a limited amount of journal articles out there, but the women that did present, there was a sudden onset of pain. They had pain, pallor, paresthesias, and then in some of the cases, they also had paralysis. I just thought this was an interesting case to keep your differentials broad whenever anyone presents with any type of left lower extremity pain, because it can be a rare phenomenon such as Leriche syndrome. Any questions?
All right, so I'll ask a question. Can you guys hear me? So my question is, so it looks like, how can you differentiate, at least from my understanding, Leriche syndrome versus like acute limb ischemia in the setting of a female patient?
With the Leriche syndrome, they will have that significant stenosis of the abdominal aorta with the occlusion of the iliacs.
If you don't have any other questions, then we'll move on to the next presentation. Thank you.